Good evening, everybody.
Yeah.
Welcome to TAVR Conclave from AIG Hospitals. Welcome, Dr. Attizzani. Thanks for joining us. Thanks for giving your time. It's probably early in the morning for you. Thanks, Dr. Anantraman and Mr. Rahul Gupta as well, Dr. Rahul Gupta. And it's going to be an exciting 1.5 hours of a lot of lectures, which have a lot of difficult problems that we need to address. And I think I'll ask my colleagues also to speak. Swaroop, Rajeev.
Yeah. So, good evening all, and thanks for participating in this AIG TAVR Conclave. Good to see Dr. Attizzani it's early morning for him. Good evening, Dr. Anantraman, Dr. Gupta, and I'll ask Dr. Rajeev to give the introduction of the program and learning objectives.
Yeah, good evening everyone, and at the outset thank you everyone for joining at this time, especially Dr. Attizzani. As you can see the list of topics which have been put forward, we have a combination of topics which will help the people who are doing TAVR right from the basic aspects to the most advanced aspects. There is something for everyone. And we hope that at the end of this exciting 1.5 hours discussion, we'll be definitely more knowledgeable and we'll feel more confident when we take care of our patients for TAVR once we get into the cath lab again. I'm sure almost everyone who is there attending this conference knows all the speakers, but it's my duty that I introduce them just before they give their talk. We'll be starting off with Dr. Rahul Gupta, who heads the Department of Cardiology in Apollo Hospitals in Navi Mumbai, and we would request him to start with his talk and enlighten us about how the different alternative access can be used in TAVR in today's age. Over to you, Dr. Rahul.
Yeah, thank you, Dr. Rajeev. Good evening, everyone, and good morning, Dr. Attizzani. And hope to have good comments from you. And so I'll share my case, and that will help us to learn a lot from him, a lot from everybody of you, and especially Dr. Attizzani. I'm sharing my screen. Yeah, I hope my slides are visible. And
yes, very well.
Yeah. So, I think the most preferred site for TAVI has been transfemoral, but I think I was going through the literature, and about 5 to 15% of TAVI candidates do not have a favorable iliofemoral anatomy for a safe transfemoral access. And we all know that technology has advanced and operator expertise has improved, and other route of vascular access and TAVIs have emerged, and there are various routes which are there. And I think we can discuss about various routes, but I had experience of doing transcarotid as well as subclavian. I'm going to discuss a transcarotid case which I did, and I found it that it was quite easy when so we'll go through that case and we'll try to learn. So the first Menon TAVI happened with transeptal antegrade approach, and then there have been transapical, transfemoral has already been there. Transapical has gone down, but the transcarotid, transcaval, all those, the subclavian axillary, all these have emerged. There is a recent, discussion about percutaneous transsubclavian, because when we go to alternative access site, we need surgeons with us. But with the percutaneous approach, I think that need will go away. So that these are just the various approaches. I will try to put a little bit about how to set up the operating room in the last after I discuss my case, and then we can discuss forward. So I'll begin with my case. Now this is a 80-year-old female, 45 kg, frail lady, diabetic, hypertensive. She underwent a bypass surgery in 2011 with a Lima to LAD and a SVG graft to RCA. These were the two grafts that she had. She had survived a uterine cancer and was cured. And she presented to us with significant LV failure, one episode of syncope. And the echocardiography revealed gradient despite low ejection fraction. Her gradient was 90/54, mean of 54 LVH. There was mild to moderate MR, mild TR, and about severe PS. So we can see there is a regional wall motion abnormality in the LAD territory. This is the ejection fraction which was there, which looks slow. There is an MR which is there, LA is dilated, and there was a TR and a PH, and the gradient was significant. So let's go to the CT analysis of this patient. This patient, the mean diameter, whether it was perimeter derived or the mean of maximum, it was around 21. The only thing which I think every other parameters was okay, whether we look into the coronary heights and all. If we look at the iliacs, just look at this minimum diameter and the 3.4, 3.6 on the right, 3 into 5.0, 4 point, very, very low diameters. And the left subclavian also was quite, small, 4.3 into 4.4. And she also had a patent lima to LAD graft. So this was the findings out of the CT thing, and these are various dimension, calcification, the sinus heights, the coronary heights, the angulation of the aorta, which was quite okay, favorable. This is what is more important, and this was something which we need to deal with it, appropriately as to what should be the access. So this is a heavily calcified 360-degree angulation. We can see the middle picture and a diffuse calcification of the right iliofemorals, and similarly on the left side we see that the significant calcification. So 360-degree calcification, dense calcification, and I think it can be a tough job to crack this kind of calcium. And the subclavian artery showed a patent lima to LAD graft, but the diameters were not, because if we go through the artery, the perfusion to the lima can go down. We can discuss about how to do these kind of cases as well. So this patient fitted into a 26 millimeter evolute with which I did the case. So issues in this case: highly calcified, severe bilateral iliofemoral disease with 360-degree calcification at some places. Left subclavian access is also not suitable due to smaller diameter and lima to LAD graft. Right subclavian diameter and approach was also not feasible because of the angulation. So we studied the carotid. So this was all happening in the heart team. The right side common carotid artery was okay. However, there was severe stenosis of the proximal internal carotid artery, and left side CCA was okay, and there was mild disease in the proximal ICA. So these are the velocities. We can see on the right side there is a 230, which is a significant velocity in the proximal ICA, but we wanted to keep this route ready in case we are not able to go through the femoral access after a good bed preparation. So MRI brain, intact circle of Willis, and this was the MRI report where it showed that there is nothing, the circle of Willis is okay, and there is a moderate to severe stenosis in the right ICA, as well as the left ICA is only minor plaque. So the approaches which we thought possible was we'll take the left common femoral artery for the right radial for the root angiograms, and right CFA we'll use as the main axis after preparing the bed using the shockwave lithotripsy balloon dilatation. That was the plan, versus directly going about the right carotid axis. But the surgical team was a little reluctant. The patient's relative, when discussed about the stroke risk and all those things, they were little reluctant. So we thought we will go all ahead with full preparation of the with the right CFA, and if we are not able to do, then we will perform this. Direct aortic access were also considered, but ruled out due to frailty. The surgeons were not comfortable. So place the balloon tip pacemaker through the IJV. This was a shoot of left CFA. CFA was not palpable, so there was no good backflow after the fluoro-guided puncture, and therefore I decided not to go through this. And pictal for the root angiogram was played through the right radial, through which I took the shoots of the both the sides, which were showing the flow on the right and left side, but somehow during the left CFA puncture we were not able to get the backflow, and therefore did not go through that process. Under the fluoro guidance, I punctured the CFA, confirmed it whether it is above the bifurcation, and it looked above the bifurcation. So now, after putting the wire, I was not able to cross even the 7th French sheath couldn't be negotiated. So dilated it with a balloon, initially a 5O balloon, to take it up. These are all those balloon dilatation picture. This is getting inflated. So inflated at few places just to allow that. And after this was done, the idea was to take the IVL balloon. If you look at the movement of the balloon also, it was coming out with quite a significant time. Now this is the roadmap, and with the roadmap on the most critical site, I started giving the pulses with the 7x16 IVL balloon, and delivered the maximum pulses at the site which appeared the most critical, which we can see over here. And these multiple sites, the impulses were being given. The shoots were taken in between to see how things are looking. So there are 300 impulses, 30 impulses, 1 cycle IVL. So these are the dilatation relatively, and it was looking promising that the site must have opened, the calcium must have cracked. These were shoots which were taken intermittently just to see whether there is no perf or anything. So post dilated with 7x60 balloon again, but the sheath refuses to go. So you can see the movement of the entire iliofemoral system when we are trying to put the sheath, and it refuses to cross. So this is the picture after this, the sheath, 10 French dilator to dilate the tract. So this is how the 10 French dilator is going with great difficulty. It's not moving that easily. So dilated with 8x40 balloon because it looked that it needs further dilatation. We had already exhausted 300 impulses at the tightest site. The balloon appeared to be decently opened, only except at the site which looks the most critical, the just above where right now we are seeing the balloon. Then the 12 French dilator is now crossing. So I could take it, the long dilator. The 14 French dilator doesn't cross again. So this is the difficulty, again phased. So again dilated with the balloon. Finally the 14 French dilator crosses with some difficulty. So idea was that if the 14 French dilator can cross, we can just keep the sheath, the inline sheath at before the tightest lesion, and just navigate the valve across the lesion and deploy it. Now balloon dilatation done at the site of maximum resistance. These are those pictures taken after this. No perf. The 12 French sheath was introduced and the valve was crossed. So this is how the valve crossed, and after crossing the valve, all these exchanges were done. The fluoro check of the valve was done, and the valve was dilated with 18 mm ZMAT balloon. So this is the dilatation which happened, and with the pacing, I think it dilated completely. So we'll just go ahead. Now, still, we were quite hopeful that we will be able to cross the iliofemoral lesion because the dilator went, but it's not able to cross. Maybe it is, again, getting collapsing, and we can see this Swaroop image where we are trying to push, but the valve refuses to go. So the idea was probably there is some spur, and all of us thought we put a 8x60 fluency stent which was deployed and post dilated at high atmosphere. The thought was that probably it will take away the calcium spur which might be protruding and causing the difficulty, and after that we dilated it at high pressures. These are all dilated pictures, and then this was the image, and then again still not able to navigate the valve. So this is where we are stuck. It's already a lot of time. Heart team discussion planned for right carotid approach. Pacemaker now changed to the femoral vein. Pigtail for root angiogram changed to the right femoral artery, and patient was put under GA, right carotid exposed by the surgeon. Crossing and deployment got over in next 25 minutes. So this is the femoral placement. This is the wire going on from the carotid, the right carotid. We chose the right carotid because the right carotid was severe. So anyway, if it is occluded, the left side was providing the separation to the right side. So that's what we thought, and the common carotid was quite, it was healthy. So this is the valve deployment. The flaring of the valve is opened up. We checked the angiogram. No significant leak, and then we deployed it. This was the shoot, and these were the echo picture post TAVI. There was a mild paravalvular AR. The gradients were hardly anything, single digit gradients. And the MR, if you look at what was looking at mild to moderate, has disappeared, except the mild. So for the clinical course, she required 2 PRBC because during a lot of exchanges there was blood loss. She developed a right lower limb pain the next day. CT revealed complete occlusion of CFA with thrombus, which was treated with embolectomy by surgeon. The proglide had misfired, malfunction due to calcium on the arterial wall, and patient was given femoral artery compression and a tight bandage with sandbag, which may have led to thrombus formation because she was kept on that, and she was a pale lady, so maybe it got compressed for a little longer, and that led to thrombus formation the next day. Patient is doing very well at 4 months follow-up. I think PVD is not uncommon, and we may face a lot of difficulty as in this case, and we're quite hopeful that IVL would help, but it did not work in this case. Good heart team discussion and workup should happen beforehand, so that in case we need to change the alternative side, it should happen quickly. There was some resistance from surgeon as well as relatives for exposing the carotid for the fear of stroke, so therefore we kept struggling for the femoral side. The position of all operators in the cath lab should be reversed and discussed in alternative side. And as the experience and comfort of operator keeps increasing, alternative access site will become more common. Vascular access management is one of the most crucial steps. I'll just go through the little bit of data on the subclavian approach if I have time, I think 2-3 minutes. So the subclavian implantation expands patient access to TAVI, and subclavian approach provides an alternative for TAVI for patient whose iliofemoral anatomy is compromised, as we saw, and subclavian arteries are often viable in patients with compromised femoral and iliac arteries. And this access often presents a better access angle for patients with extremely angulated or horizontal aortas. So left subclavian for around 70, right subclavian we need aortic root angle less than 30 degree more vertical, and this is how the angulation goes when it is left and the right subclavian artery, and most appropriate access route selected based on the anatomical characteristics. And for if there is the Lima graft, we should either use a contralateral subclavian or axillary artery or direct aortic access or a carotid access, or we should have if we are using the diameter has to be good enough so that the flow to the Lima is not compromised, and if there is a sign of compromise, the perfusion, if compromise are there, then we can adjust the introducer to maintain an acceptable perfusion. These are various options where the operators can stand. One of the operator is at the side, the same happens with the carotid. The other operator usually is at the same as we use in the transfemoral approach, and based on the comfort level, we can use the various positions which are there. We'll not go into the details of how we access, and these are all those deployment with the subclavian access, but it happens quite easily. We just go through it so that we have more time to discussion. And this is about the carotid. So there are certain needs, advantage and disadvantage of each approach. This case had a transcarotid, minimal vessel diameter 6 mm, calcification and tortuosity, short neck, all those things, anatomical consideration, prior ipsilateral carotid artery intervention, stenosis or occlusion of contralateral carotid arteries or vertebral arteries, anticipated difficult airway, and mode of anesthesia is usually general or local with conscious sedation, depending upon the surgeon's choice. The advantages are no interaction with descending and abdominal aorta, no myocardial injury, no chest wall injury, no entry in the pleural cavity, no restriction in presence of prior cardiac surgery, rapid recovery. And we have to manage all these access preparation, but I think a good surgical team can help us in dealing with this. Direct carotid approach, mini thoracotomy versus mini sternotomy. We will not go into the detail. I think we'll leave time for discussion. Again, same different positions, and I think these are the points which I wanted to tell. So thank you very much. I hope we can have some time for discussion. Thank you.
Yeah, thank you, Dr. Rahul Gupta. I think fantastic overview of alternative approaches. I think we'll start taking comments from the panel members. We'll start with Dr. Attizzani. His comments are alternate access nowadays different compared to what it was when TAVI started.
So congratulations, the kids, Rahul. You were very, you worked hard on that right femoral artery there. I think I would have tried the same strategy as we did. I would have tried with shockwave, and honestly, I was surprised it didn't work. You did all of the shocks and you did the multiple balloon dilatations, didn't work. I think the choice of carotid, right? There is the fear of stroke, but there is data showing that actually carotid access has less stroke than subclavian, right? There's this data that is going to come out soon from the TVT registry that Mike Caskey presented on TCT, showing lower stroke rates with carotid access compared with subclavian. We here, because we have a lot of comfort with left subclavian access, this is our alternative access of choice. I think we have to master at least 2 alternative access, although they're very rare today. I like to use the left subclavian, and we always do it with cut down. So why do we do cut down and not percutaneous subclavian? Because to start with, we always have our surgeon in the room. The way it works in the United States is just like that, right? So in addition, these patients, they have poor peripheral access per definition, and the cut down takes 5 minutes for the surgeon to expose the axillary artery for you. And if you have a complication in a percutaneous approach, you are going to have trouble because you have to put a balloon to occlude, etc., right? Of course, it's feasible, but we do routinely cut downs on our subclavian cases. I think you made a very important comment in terms of the lima. We've done cases of left subclavian with lima, but you have to make sure the diameter is okay for you to not have ischemia. And another thing that I always do when I do subclavian access, I always work through a sheath. I never go sheethless, because I feel like I put the sheath right in the ascending aorta, because I feel like you minimize all of this exchanges and everything. I think it reduces the likelihood of stroke. Can I prove that? Well, we have very low rates of stroke, even with subclavian access here. So I feel like that works very well, at least for us. As you said, transapical access, I think nobody does transapical access anymore with SAPIEN, obviously. And direct aortic is always an option. I think if the patient has a virgin chest, not very frail, it's an option. I think we do a direct aortic case once per year here, maybe, or once every 2 years, but it's an option. I think it was a great case. I think our considerations are very valid. And right subclavian with evolute is very tricky. As you said, the angulation of the valve is totally different from left subclavian. So I would recommend that right subclavian is done by experienced operators with evolute. It's not, the implantation is a little bit trickier than left subclavian. Thank you.
Thank you for the comments. Thank you.
Yeah, thanks, Dr. Attizzani. Dr. Anantraman, any comments from your side?
That's a fantastic case, Rahul sir. It's very nicely done. And as Attizzani has already mentioned, nowadays, because of the availability of the IVL, we always want to see whether we can optimize femoral and complete it, because the best outcome we still get is transfemoral. But alternative access we should have, and it depends on the center's comfort, your surgeon's comfort. And because of our surgeons are, because most of our surgeons are comfortable with cut down axillary, as he mentioned, because of the impel loss and other things. They're very comfortable. They open and give in 5 minutes and close in 5 minutes, no more than that. Occasionally we have done high iliac grafts. These cases, if your vascular surgeon is good enough, you can put a high iliac graft, complete it, and then close the graft. So the procedure is done and dusted. Otherwise, it's very, very nicely done and fantastic result.
So we were struggling for 4 hours with the transfemoral and completed within half an hour through transcarotid.
Yeah, Anuj, Swaroop, any comments from your side?
No, I think amazingly done case. A lot of hard work, a lot of patience I think went into it, and I think a brilliant result at the end of the day. Great.
Yeah, it's a great case by Dr. Gupta, and I like that stepwise approach. Still, every effort was made to go transfemoral before switching to the alternate access. Just as Dr. Attizzani mentioned, I was also a bit surprised that after IVL also the balloon was expanding, but the wall didn't track. But it does happen, and ultimately case was finished elegantly. Congratulations.
Just one comment which I want to make is, we were all happy that everything has gone well, patient was extubated and everything gone well. But one thing, the pressure thing which nobody realized, that a huge compression on a frail lady that led to again a femoral thrombus, which next day we had to dealt with again with embolectomy and all. So that is one thing which we also that is a very important thing which we all need to remember.
Yeah, thanks so much, Dr. Rahul Gupta. Fantastic case. I think we'll move on to the next presentation. We have Dr. Uday with us, young budding TAVR specialist. Does a lot of literature search. So he's going to tell us something about how to handle TAVR in a small annulus. Over to you, Uday.
Good evening, everyone. Thanks for your kind words, sir. So, okay, we'll start my presentation. Is my screen visible to all?
Yeah, go ahead.
So, my topic today is supraannular advantage specific to small annuli. So, aortic annulus is basically a complex three-dimensional crown-shaped structure, which is the integral part of the fibrous skeleton of the heart. Whenever we talk about a surgical annulus, we relate to the anatomical ventriculo-aortic junction where the suture ring is placed. And coming to the TAVR, whenever we discuss about virtual basal ring on CT, it is the imaging ring formed by a plane that passes through the basal attachment of all the three leaflets. So, two-dimensional imaging may not be sufficient to adequately image annulus, and three-dimensional imaging should always be used. So, coming to the definition of small aortic annulus, annular area less than 400 millimeter square, perimeter less than 72, and mean and minimal annular diameter less than 23 or less than or equal to 21 comes under the category of small aortic annulus. This is on the CT. So, prevalence varies depending upon the method used, but it is more generally in the Asian population, and 90% of the patients with small aortic annulus are women. So, what are our concerns with small aortic annulus? It basically starts with assessment, because most of the times, because of the more pressure recovery phenomena seen, gradients may be falsely inputted as high, and during procedure, most importantly, patient prosthetic mismatch is more seen with small aortic annulus. And whenever there is aggressive pre-dilatation, post-dilatation or oversizing, we can come across annular rupture and coronary abstraction. On the other hand, PVL and PPI are relatively rare with small annulus. They are generally more seen with when we are dealing with the large annulus. So, coming to the patient prosthetic mismatch. So, basically, whenever the effective orifice area of the normally functioning process is too small in relation to the body size, it results in inadequate cardiac output, both during rest and exercise. So, this compromises the hemodynamic and the clinical quality that we offer after TAVR to a patient. So, moderate ppm is anything between 0.65 to 0.85 centimeter square per meter square, and severe ppm is less than 0.65 centimeter square per meter square. And in patients whose BMI is more than 30, ppm is overestimated. So, we have to correct it, and it is somewhere between moderate is less than 0.7 and severe is less than 0.6. So, with ppm, what generally happens is, because of the increased shear stress and turbulent flow across the valve leaflet, there is earlier structural valve deterioration, which can negatively impact the longevity of our TAVR valve, and there is less LV mass regression leading to diastolic heart failure hospitalizations, and the normalization of the coronary flow reserve post TAVR doesn't happen, and there is reduced exercise tolerance and quality of life. And most importantly, as shown in many studies, there is increased all-cause mortality at 1 year in the severe ppm group. So, out of the TAVI small registry, we have a little predictors which would reduce the risk of the ppm. They are like oversizing by more than 15%, pre and post dilatation, and intraannular leaflets might actually increase the risk of ppm. So, from the same thing, when we compare various self-expanding valves, what we could see is Evolute R, Evolute Pro performs best in case of low gradients and high indexed area, and Portico fares worst, and Evolute R and Accurate come somewhere in between. So, we'll just, with this background, go to our case example. 75-year-old lady, angina and dyspnea on exertion since last 6 months, progressive, is a diabetic, hypertensive. BMI is normal, ECG is normal, echo showed severe aortic stenosis. It's a bicuspid aortic valve with good LV function, and peak gradient was 74 and mean was 46. Aortic valve area was 0.7 centimeter square per meter square. Angio was normal. So, we did a CT for her, and here you can see the mean diameter is 18.2, perimeter is 59.8, and area plus 256. LVOT is also almost similar measurement. So, this comes under a clear small annulus. Apart from that, rest of the measurements like sinus heights, sinus diameter, coronary osteohyte, rest of the things were all normal. Here you can see it's a type 0 bicuspid aortic valve with a little calcification seen on the non-coronary side. And we have a decent vascular access. So in this case, it's except for the small aortic annulus and a bicuspid aortic valve, it's a pretty straightforward case. So we chose 23 mm valve, around 21% oversizing. We were compatible with that, so we went ahead. So baseline angiogram was done, both in the levo and coplanar view. So here you can see a little calcium. Then we took the gradients, which were in concordance with the echo gradients. Peak to peak gradient was around 70. Then we did a pre-dilatation with a 16 mm balloon and a simultaneous angiogram. So we generally prefer to do bicuspids to pre-dilate, and simultaneous injection will give us additional information about how the leaflets are behaving while we inflate in respect to the coronary, and also where the actual anchoring is happening. And this is comfortably able to see. Here you can see a trivial leak of the contrast. So we went ahead with the valve, 23 mm valve, had no issues. Had to recapture once because it didn't take the left cusps. So finally ended up with 2 to 3 mm depth deploying with trivial AR. So post procedure, but hemodynamics were good. We ended up with single digit gradients on CAP. Echo also showed a gradient of around 12/7. So she was discharged in 48 hours, no complications. On follow-up after a year, she was asymptomatic. ECG was normal, and there was a slight gradients. PPG was 14. During discharge, it was 12. Now it was 14, and indexed effective orifice area was around 1.1. Good LV function and trivial PDL. So coming to the summary, whenever we are offering TAVR, now we are at a stage where we should look at clinical and long-term longevity to our patients. So when we are offering TAVR over SAVR, the indexed effective orifice area and gradients tend to be better with TAVR because the intrinsic need for oversizing when we are doing TAVR, and the TAVR valves have generally thinner struts and there is absence of swing ring. Coming to the self-expandable and balloon expandable, supraannular leaflet design doesn't have that additional annulus constraint, and percentage oversizing is also generally more when we use a self-expandable valve. When we are using balloon expandable, the percentage oversizing is a little less because we are worried about annular ruptures and all in small annuli. But the flip side is we may end up with some residual echo gradients at discharge, but they should be noted as a new baseline gradients for follow-up. And on follow-up also, if there is any increase in the gradients, we have to confirm by echo and CAP before we order any redo TAVR or valve TAVR in these patients, because there is a discordance. TAVR trial showed that there is a discordance always between echo and CAP gradients, especially exaggerated in the small angle. And future directions, because none have addressed about the effect of calcium in the aortic annulus and LVOT, or whether depth of implantation would change the outcomes in small annuli. And there is no direct head-to-head randomized comparison between self-expanding and balloon expandable valves. These should be addressed in the SMART trial, which will mostly tell us how to proceed with small annuli better. Thank you.
Yeah, thanks for that elegant presentation. I'm sure each one of us really are afraid when we come across a small annulus, basically because we don't want patients to come back with PPM and then after spending so much, they tell you that they are still feeling uncomfortable. So over to the panel, Dr. Attizzani.
Great presentation today. I think I could not agree more with you. One thing you said in your last slide, that the hemodynamics of the supraannular valve is not only better because of its nature of supraannular versus intraannular, but also because you can oversize more liberally as it is self-expandable. So that combination really leads to excellent hemodynamics, because you can not only oversize more aggressively, but also you're relying on the fact that that's supraannular. So that's very, very important. We all know that patient prosthetic mismatch is not a good thing to have. It's associated with higher rates of structural valve deterioration and mortality, right? So there's data already showing that. And I think whenever we have a discussion in our heart team discussion on what kind of procedure we're going to offer to our patient, it needs to take place this discussion of it's TAVI with which valve, right? And versus surgery, what kind of surgery, right? You're going to put a small surgical valve versus doing a root enlargement. So that's why it is important to really understand what kind of procedure you're offering to your patient, what type of valve you're offering to the patient. As you mentioned, the SMART trial, which is ongoing right now, I'm part of the steering and the screening committee of the study. We're very excited about it because we're going to be able to to shed some light on this very important topic. And just last comment is that I strongly believe that this hemodynamics of the supraannular valves is really better than intraannular, and we were doing a study here with post-TAVR stress MRI that we're looking at the performance of these devices after exertion, right, post-TAVR, and we're going to try to publish this data soon. It's already in the process. But I think we have very good data showing that evolute hemodynamics is really good, and when you exert a patient, that might be even more pronounced. Thank you.
Yeah, thanks, sir. Dr. Anantharaman, any comments from your side?
No, it's a very nice case and fantastically presented. And I think Attizzani has already covered most of the important aspects of the importance of supraannular valve, especially in this smaller annulus, which we have quite a lot, and more so for valve, which I'll be showing in the next presentation. We have a lot of valves which are less than 21 millimeters, and there is a lot of things to think about, which I'll be showing on this label sizes, internal diameters, various things, where the supraannular does make a big difference. So as such, for the hemodynamics, and for oversizing, for all aspects, it is probably the best option. And end of the day, we should leave the patient with no patient process mismatch or relatively very low patient process mismatch. Otherwise, you will be replacing a stenotic valve with a stenotic TAVI valve, which is not good.
Thanks so much, Dr. Gupta. Any comments from your side?
I think all points are covered, so we can't emphasize enough that supravalvular the evolute platform has been always good for the smaller annulus. I think all the comments were taken.
Anuj, Swaroop.
Rajeev, I think Amit has also joined.
Yeah, I can actually see Dr. Amit. Welcome, Dr. Amit. I think he is in a car and the signal is breaking in between. So he's actually requested his presentation to be kept last. I would request Dr. Amit to just write down all the points, so that once you reach a stable place, I think you can enlighten us with all your suggestions about all the talks which have been given, because I think the signal is not stable presently.
Yeah, so, I think on the flip side, for a small annuli, in the similar kind of case, I think surgeon would have put probably a 19 or 21 valve. So I think as time goes by, I think for small annuli, TAVR will become the treatment of choice compared to surgery, even if it's a low risk. I think that will be the way to go.
Yes, I think Uday covered most of the points, and Professor Attizzani also further elaborated on that. I think the incidence in Asian population is slightly more than the West. The Ocean Registry, which was published from Japanese colleagues, especially in female population, it is as high as 50%, 60%. The incidence is really high. So we all should try to optimize the result. And what Dr. Anantharaman mentioned, that you don't want a situation where you have a stenotic TAVR valve in an aortic stenosis patient. My question to Dr. Attizzani is, because this is a combination, isn't it? Small annuli, small sinus of Valsalva, peripheral vessels are also small. So is there any theoretical advantage of the shape of the evolute as far as the coronary occlusion is concerned? Whether does it have a low risk of coronary occlusion because of the central constraint or configuration of the valve?
So yeah, so of course when you have a small anatomy, right, depends on when you start combining small STJ with small sinuses and low sinus heights, that increases the likelihood of coronary occlusion. the evolute, the likelihood for coronary occlusion with evolute is highly dependent on that, and similar, I should say, with SAPIEN as well, right? I feel very comfortable with using evolute in situations that you have, for example, a little bit of a narrow sinus but a big STJ, even if it's a low takeoff. I start becoming uncomfortable when you start combining those, like smaller sinus, small STJ, low takeoff of the coronaries or low sinus height. That combination becomes a problem. The chance of like acute coronary occlusion also, it's important that you can, with evolute, determine your depth, right? So if you're concerned with potential for coronary occlusion, you can go deeper, remembering that the skirt is either 13 or 14 millimeters, depends on the size of the valve you're using, right? So we can go deeper, right, to not have that skirt in front of the coronary ostia, right? Of course, paying the price of pacemaker if you're deeper. So I think with evolute, you have more control. In addition, there's an additional factor, which is the possibility of injecting, right, at 80%. And taking a picture and understanding whether or not there's coronary occlusion. That picture you have to be very careful, because even if there's no coronary occlusion, right, you may still occlude the coronary after the final release, but that's something that can help as well. People have been, after the advent of Basilica and everything, right, and Chamini stent, we very rarely protect coronaries here. Last year we've done close to 360 cases and I protected 0 coronaries, no protection at all, right? I remember, I think there was one case that we didn't do. We ended up sending for surgery with root enlargement because there was a very high risk for coronary occlusion. It was a low surgical risk patient. But yeah, so I think it's important that we understand the anatomy and always the combination of the elements is what leads to trouble. If you have only one, for example, just a small sinus and wide STJ, high takeoff, I'm comfortable doing evolute without significant concern for coronary occlusion.
Thanks.
Thank you so much. I think we'll move on then with the next presentation. So we have requested Dr. Anantharaman to go ahead with his presentation. I'm sure everyone knows Dr. Anantharaman. He is in Chennai in Kaveri Hospital. He is one of the pioneers of TAVR in India. And there's probably hardly any TAVR operator in the country presently who has either not worked with him or not been mentored or taught by him. So we are all waiting to listen to you, sir. Over to you.
Thanks, Rajeev. Thank you for that kind introduction. And I'll cover the valve in valve, some of the basics, and also on the aspects of balloon valve fractures and up-to-date evidence. Now, since the invention of the TAVI, the number of surgeries have increased. That is something we have noticed in UK for 20 years, and that's the same in US and India as well. Previously, patients who were rejected for surgery were taken for surgery. So the number of aortic surgeries have increased. Along with that, mitral also has increased. But what has increased along with that is, irrespective of the age, as this graph shows, bioprosthetic valve usage has increased because of the confidence that we can go in and intervene again with a TAVI valve over a period of time. So this shows that irrespective of the age, less than 55 up to more than 70, the number of bioprosthetic valves have increased. But the durability of the surgical bioprosthetic valves have not changed, as shown here. The porcine is in the sort of reddish dots, and the blue ones are the sort of pericardial valves, the bovine valves. Bovine valves fare slightly better than the porcine valve, but over the sort of after 10 years, there's not much difference. So the mean kind of durability for the valve is around 10 years. And the recent guidelines, both American as well as European, advise TAVI as the first choice if the patient's surgical score is high, or if there are other indications like frailty, porcelain aorta, and all the other indications we know of. It's the same for the valve in valve as well. And the main thing is here, the most important thing is the hearting. So the hearting decision is important. It's not the age, it's not the other things. You have to put everything together, you have to put it to the hearting, and you come up with what is best for that particular patient. So the first case of valve in valve TAVR in India, I'll show that. And this was sheathless implantation of a core valve. I repeat that, it's a sheathlet implantation of the core valve. I'll tell you why it was sheathless. This was 81-year-old with multiple comorbidities, Edwards Perimon 21 millimeters, previous CABG, and a carcinoma of breast, radiotherapy to the chest. Now symptomatic aortic stenosis. So started in 2014, and I saw her in 2015 when I was working in Cherian Hospital. Moderate LV impairment. So we reviewed and we accepted. That's the time I just came back from UK that we will do a valve-in-valve TAVI. Now the CT scan was done, everything was suitable, and it was sent to Europe for cropping sort of report as well. Now this was done during the time where we have to import the valve, so that we have to get the CDCO's approval, and it takes a good 6 weeks from your application up to the approval to get the valve. And that was a CT scan. There is heavy calcification, as Rahul showed in his case. It is heavy calcification, and it is circumferential. Now it is very important, as Rahul has shown in his case, it's very important when you have a 360-degree circumferential calcification, even though the diameter here is more than 6, this is what's fooled us. Both myself as well as the European doctors, that it should be possible to complete it through femoral, and we've taken it for the femoral case because the patient has got a functioning lima. There was heavy calcification, porcelain aorta, and radiotherapy to the chest. So left side looked bigger vessel, but nothing will go through, more than a 12 French sheath, and the vessel was ruptured, so the surgeon has to repair it. The right side again the same. So heavy calcification. In the end, this was before the time of IVL, this was 2015, we didn't have any lithotripsy balloons. We can just about get a 14 French sheath. So we crossed the valve, and because it was a surgical cut down, the surgeon created a loop. We couldn't get the 18 French. Through the loop, we deployed the core valve without sheath. So it's just over the wire, and it was deployed. And that was the first valve-in-valve in India, and she did well. It took about 6 weeks for her to recover. That is the team. And that was covered in all the media papers. At 5 years follow, 5.5 years now, she's doing well, absolutely well, and asymptomatic. So these are the whole plethora of valves you have: stented, stentless, porcelain, bovine. You need to know what valve the surgeon has put. Every valve is different. And there is a plethora of transcatheter valves. I think by next year we'll have at least 6 different valves available in India. Again, you need to know which one can be used for that particular patient. If you're not sure about the valve that is used, some of the sort of help can be obtained from the fluoroscopy. Depending on the fluoroscopy, you can tell which valve is approximately, and also which valves you can use it. The very basics, stented with the leaflet inside, you will have a stent post, you will have a base ring, and you will have a leaflet inside. This is the worst one, where the leaflet is outside, so you have to be wary of that. If your patient has a leaflet outside, you have to be wary of that. And this is what I was alluding to earlier on. If you say a 21 valve, the surgeon is saying about the outside diameter of the stent. But what we are interested is the inner diameter is what is available for us. That is the most important thing. And for a 21 of different makes and size, you can see the diameter is very much different. Depending on which valve, your diameter varies between 17, 18 up to 19 for the same 21 valve. Again, that you need to be aware of. So know the pathology of the valve failed. Is it stenotic? Is it regurgitant? Know the valve that has been used, and know what valve you are going to use based on that. And also have the adjuncts like balloon valve fracture or basilica, depending on the valve, as well as the leaflets. Especially less than 21, in this day and age, we should go with the open mind of balloon valve fracture. So make sure there is no concomitant paravalvular leak. Make sure that you assess the CT properly. Make sure you know what the valve it is, and have a good hearting discussion. And this app will help. It is only an aid. It is not 100% kind of guidelines. It is only an aid. Remember that. So end of the day, you need to achieve the best hemodynamics for your patient. So 2 things important: the depth of the implant and balloon valve fractures in less than 20 millimeters, 21 millimeters valve. The implant depth is important because if your implant depth is just spot on, the mean gradient is about 10 to 15. But if your implant depth is more than 30, in 40% of the patients you will get a higher gradient, and also you will get an orifice which will look like this, both balloon expandable and self-expandable. So the implant depth is important. and the gradient will depend on the implant depth. And the balloon valve fracture is important for all the valves which are less than 21 millimeters. Now, how do you do it? It's very simple. Obviously, you have this syringe, 60 ml syringe, 1:4 contrast mixture. You have the dilator, the inflator ready. So you open to the syringe first. It's better if the two operators does it. You inflate the syringe first. You can see the waist. Then you open it to the inflator and you go up until you see the waist gone. Once you see the waist gone, the pressure in the inflator also will drop. That means you have fractured the valve. Then you deflate both. So it's as simple as that, but it's better that two operators does it. And some of the valves will be fractured at 8 atmospheres. Some of them will go up to 18 atmospheres. So again, know your valve and know what pressures you are going to go. Some of the valves are modifiable, some of them are fracturable, some of them you cannot do anything. Hancock and Elvis, you cannot do anything. So this is modification, there is still waist, that is fractured, the waist is gone. And this is after implant, this is after correction. And this is a case that was done last week in my center. It's a 21 biacard, implanted in 2012. You can see as soon as implanted the W23, there is a waist. This is the first balloon inflation. There is still a waist. It's not gone up. I'm still getting a gradient. From 45, I was able to reduce it to 30, but still not enough. So the same Atlas Gold with the inflator. So first with the syringe, and then with the inflation device, up to 12 atmospheres, then the waist is gone. And the gradient came down to 12. And discharge echo gradient was 12/7. So we have to aim for that kind of result in most of the patients. Whether you do before or after, it depends on the comfort and the hemodynamics of the patients. I prefer to do it after the valve is implanted in most of my cases. That gives comfort. Basilica is as simple as that. You can go in and have the leaflet, but you need to have good experience as well as for initial cases, it's better to do with a colleague who's done it or have a good support. So coronary obstruction, 50% mortality. You need to have at least 4 millimeters, the VTC. I'll show you what it is. So this is some discussion we were having about the sinus. So the type 1 is you have a good sinus, the coronaries, and your valve is below that coronary and the STJ is above. That is a very, very suitable and good one. In places where the valve is above the coronary, the stent post, but still a huge sinus, you don't need to worry. This you need to be concerned about. The same if your valve is above the STJ, with a big sinus, you don't need to worry. But a FA sinus and narrow sinus, you need to have some kind of coronary protection or a basilica procedure. The downside with the chimney stenting with the coronary protection is it will give you a good result on that day. But 6 months, 1 year down the line, this is what will happen. You will have significant stenosis or problems. So we were doing quite a lot of these chimneys, but we have stopped doing it now. It's not a good procedure. Yeah, this is after 6 months. So basilica is a much better procedure. You tear the leaflet and you go a good valve. The numbers are increasing, the valve-in-valve numbers are increasing. The outcomes are good with good experience, both balloon and self-expandable. The outcomes are good, especially with the valve fractures. Compared to surgery, definitely the valve-in-valve is much better in terms of the second procedure. And the meta-analysis confirms that the valve-in-valve is as good, or if anything, it's better than the redo surgical procedure. So you have to do decision making based on your heart team, based on the patient. Lifetime management, this is probably future, a lifetime management of the valve, whether we put a TAVI valve first and then ask the surgeon to replace it after 10 years with a bioprosthetic valve, then we put a TAVI valve-in-valve. So that gives a good 30 plus years for a patient with valve stenosis starting at 40 to 60. And that probably will be the future. So valve-in-valve procedures are safe, and many patients will have failed prostheses in our setup, and valve-in-valve TAVI cohorts have good outcomes. And balloon valve fractures is a must for less than 21 valves. You leave the patient with no prosthetic mismatch, and especially if you are taking a low risk patient, leave them with no paravalvular leak and no gradients. Thank you.
Thank you so much, sir. As usual, a very authoritative presentation and a lot of points to learn. I think again we'll open it up to the panel for their comments and suggestions. Dr. Attizzani.
That was a great talk, very comprehensive. I think I just have some very few comments on it. Is that number one is that we only use Evolut for valve in valve. I really believe that the hemodynamics of the supraannular hemodynamics makes a difference. Of course, when you're dealing with smaller valves, even more so, right? In addition to that, another very important point of your talk is that the depth of the Evolut valve makes a huge difference in terms of the hemodynamics. I see people talking about valve fractures a lot of time when you go to congresses and people talk about it, but then when you see the valve implantation, the valve is very deep. So you lost already the opportunity of optimizing your results by doing a shallow implant. And the magic number for Evolut would be around 5 millimeters. That's when you get the best hemodynamics. So it needs to be 5 or less, right? So that's one thing. In addition, another thing that helps a lot, and I think you mentioned in your talk as well, is post-dilatation, not valve fracture, but sometimes when you have a lot of panels, you see the valve is underexpanded, and post-dilating to the diameter of the surgical valve helps a lot to optimize the expansion of Evolut and reduces gradients. And obviously, right, when you're dealing with smaller surgical valves, despite the fact that you do shallow implant, post-dilate, you may still need to do a balloon valve fracture, as you mentioned. My last comment is that asking between doing pre or post balloon valve fracture, we all know the pros and cons of both, right? Doing it pre, there's always a risk of having an acute AI and the whole story, or eventually maybe a stroke related, if you have a dislodgement of the leaflets. My concern with post dilatation or post valve fracture is that you may also injure the leaflets of the core valve. I'm working on a study now looking at all of the data from Medtronic, right, in terms of post-dilatation on not valve in valve, but regular post-dilatation, to understand whether there's going to be a compromise in terms of the durability of the valve when you post-dilate aggressively, right? We already have some data, but there might be a compromise in terms of the long-term durability, because you're forcing those leaflets. You may cause micro rupture of the leaflet, which may, increase the likelihood for early calcification. So we will see what happens. We don't have the whole data yet, but I'm curious to see how it goes. Thank you very much.
Yeah, thank you so much for those comments. Dr. Gupta, comments from your side.
I think very elegantly presented, comprehensive, covered all the points about the valve in valve. I think beautifully, and comments by Dr. Attizzani have added on to it. I think the question which was, I think he has already answered, which I was thinking pre or post. The other question which is coming, because the stroke chances are more, so what is Dr. Attizzani's recommendation on using the cerebral protection for these valve in valve, because the stroke risk is slightly higher and so what is the practice, because right now we are not using it in India, but what is the practice over there?
Yeah, that's a good question, Rahul. We do not use cerebral protection for any patient here. Well, although there is some, data using like surrogate endpoints that you have less, insults to the brain with MRI, but the data in terms of clinical stroke reduction is not robust, right? Not at all, right? There's a lot of data showing that it's not robust, the reduction in clinical stroke. Some data in terms of cognitive impairment down the road coming from Italy, recently published on JAK intervention, but overall, there's no robust data in terms of reduction of clinical stroke with cerebral protection devices. So we don't use it. Our rates of stroke have been consistently less than 1% for years here. Last year, 0.5%, very, very low rates of stroke, which is actually lower than all of the literature studies that they used cerebral protection device. I think reduction of stroke rates is not only about putting a cerebral protection device, but also technique. There are multiple factors during the procedure that may affect that. I'm not saying here that I will never use cerebral protection device. That there is a study going on now with Boston Scientific, right, looking at exactly at that, a large randomized study. If that shows that there is a reduction in clinical stroke, I may change my mind. But today, I don't think we have robust data to use that. Then, do we select patients? Are there patients that we say, oh, this patient for X, Y, and Z reasons, I'm going to use cerebral protection device? Very rarely. I remember a case that we did a valve on that the patient had like a torn leaflet that was very, concerning, that I ended up using a cerebral protection device. But routinely, we don't do it, Rahul.
Okay, thank you.
Yeah, thanks, Dr. Gupta. Uday, any comments from your side?
Good, nice presentation, sir. Covered everything, so it is very enlightening for all of us.
Thanks, Uday. Anuj, Swaroop.
Yeah, that was a very elegant presentation by Professor Anantharaman, and as he pointed out in his presentation that the risk of coronary occlusion is almost 2 to 3 times more, especially in wall-in-wall procedure. So whatever strategy you may have, either basilica or chimney stent, it has to be preemptive, because it is found that all the meta-analysis of the data, if it is a coronary occlusion, and if you don't have preemptive strategy, then successful PCI is possible only in 70% of the cases with the high volume operators, most experienced operators. Because one of the mechanism of coronary occlusion here is actually your bioprosthetic leaflet has made a contact with the narrow sinotubular junction or STJ, and it has formed a curtain in front of coronary, and then it's impossible to access the coronary. So whatever strategy you may have, if you are not comfortable with basilica, you want to put a chimney stent, the stent preferably should be in, because withdrawing the stent would be easier than advancing the stent. My question to both of you, Professor Attizzani and Dr. Anantharaman, is delayed coronary occlusion is also described, and more so with the self-expandable wall. So what are your thoughts on that?
Yeah, definitely. I think the cases where your sinuses are narrow or FS sinus, as I showed, that is where you have to be wary of, especially the depth of the implantation has to be spot on. And if you have any doubts that your distance is going to be less than 4 millimeters, like less than 2 millimeters, then it's probably better to put a protective stent during the procedure itself. Because I have had at least 2 cases of delayed obstruction, one at 6 months and one at 1 year as well. And those were sinuses were about 22, 23, very narrow sinuses. It didn't happen during the procedure, but it happened within sort of few weeks time. So those kind of patients, you have to be wary of. The only place where I will use a balloon expandable valve is your coronary heights are very good, more than 15 to 16 coronary height, still slightly effaced sinus, and there might be a place to use balloon expandable valve and place it below the coronaries so that future access becomes easy and delayed obstruction is not there. The rest of the cases, as Dr. Attizzani said, I think self-expandable valve is the best choice, especially in the small annulus.
Thank you.
Dr. Attizzani?
I think his response was very comprehensive. I think that I think one point that was very well made on the talk is that although the chimney stent works acutely, down the road to cannulate those coronaries is going to be really a nightmare. If ever stenosis or whatever happens, it's going to be a big problem. So I agree that the basilica procedure is a more elegant strategy that will make your life easier down the road should you need to cannulate the coronaries. In terms of the delayed coronary obstruction, we've never had one here, but I've seen cases. I've seen a couple of cases in Japan when I was going there to do cases. There were anecdotal cases of coronary obstruction late, and it's been described in the literature. We have not seen here late coronary obstruction. There's always a possibility in patients with high risk features for coronary obstruction.
Thanks so much. I think that was a wonderful talk and wonderful discussion. So Now I think we'll move on to Dr. Attizzani for his talk. I think the whole world of TAVR knows Dr. Attizzani, University Hospital, Cleveland, and he's not one of the probably the most important pioneer of a minimalistic approach. And his passion for patient safety is something which is spoken world over. So all of us learned from him how to make sure that even the smallest of things is not compromised when you are planning TAVR in a patient. So wonderful to have you here, sir, and over to you for your talk.
Oh, I really appreciate that. Was a very kind introduction, but I could not stress more my passion for this and my passion for patient safety and optimization of the procedure overall, and to be extremely meticulous with every step of this procedure to achieve excellence. So I'm going to discuss a little bit of coronary access with commissural alignment. So obviously, as we talked, the coronary access after TAVR can be challenging, and the commissural alignment definitely will facilitate that, right? Specifically for Evolut Pro R or Pro Plus, as well as for Accurate Neo, that's a possibility. Whereas for Sapien, it's pretty much of tossing a coin. There is a study that my colleagues across the street here published in terms of a potential for commissural alignment for Sapien, but it's not as precise as it is for Evolut, and it's pretty much today. I feel like it's tossing a coin whether you're going to have commissural alignment with Sapien 3. So obviously, it is important when we're discussing coronary artery disease management post-TAVR, right? If you need to do pre-procedural PCI, so we try to do our PCIs. There's some controversy on this, but if we have significant coronary artery disease, we try to address it prior to the TAVR. That's one thing that obviously is important. So it's, I think, a good point for discussion. We always try to understand the likelihood of future intervention on that patient, obviously, whether or not the patient has prior CABG. Always taking into account coronary height or sinus height, the width of the sinus as well as the STJ. The combination of these is very important for you to plan and understand whether you're going to have trouble having access to the coronaries on the road with any valve that you're going to use. And definitely commissural alignment with the tools that we have today to do commissural alignment with the current technology of Evolut, using the flush port at 3 o'clock and looking at the heart marker in the outer curvature of the aorta, which increases significantly the likelihood you're going to have commissural alignment. Obviously, with the newer generation of Evolut, with the FX that is about to be launched in the United States, and we hope to do the very first case in the world here, there will be 3 golden markers, and it's going to be very easy for you to understand whether or not you achieved commissural alignment. So that's going to be to facilitate your life in that regard. Here, just a picture that illustrates all of those anatomical structures that we discussed in terms of its importance for future coronary access. And when you talk about commissural alignment, this is a good picture, so you understand when you have commissural alignment, so the commissures of the valve, of the transcatheter valve, are not in front of the coronary ostia, whereas here on the right-hand side, you can see that it's right in front of the coronary ostia, which is going to make our lives much more difficult if we need to have access to that coronary artery. So Gilbert Tang and the team here, they published this very important, I should say, seminal paper, the Aligned TAVR, but basically, the bottom line of the study is that when you have the head marker orientation, right, in the outer curvature of the aorta, as you see on the left-hand side here, the likelihood that you're going to have commissural alignment is much higher than all of the other options that you have on the right-hand side. So it is important, right? When you're doing a case, I always tell my fellows, right, after you are in the ascending aorta, and we look at this, right? And if the head marker is in the outer curvature of the aorta, we are okay with that. We feel happy about it because the likelihood of commissural alignment is much higher. And the way to achieve this is by putting the flush port at 3 o'clock. If we cross the arch and this situation does not happen, right? We don't have the head marker in the outer curvature, despite of the fact that we did the 3 o'clock flush port, then it's important to understand which patient you're dealing with. If it's a young, low-risk patient, right, what I'm going to do, I'm going to pull the valve back, reorient my spines, and try to go again to see if I can achieve this picture on the left-hand side. Whereas if I'm dealing with an older patient, right, with no significant coronary artery disease, then obviously I'm not going to bring the valve back to the descending aorta to try to reorient my spines because of the risk of stroke, and all we know, crossing the arch multiple times is definitely not a good thing to do. The ideal scenario for commissural alignment obviously would be something in the catheter that we could actually rotate the catheter while we are already in the ascending aorta to align the commissure, right? This I've been working with the engineers at Medtronic, and then there is a solution, potential solution coming in future generations that we can actually rotate. There is potentially going to be something in the catheter that you can rotate and achieve commissural alignment in that position without having to come down to the descending aorta to rotate the spines in case you do not see that. Well, why that is important? Because if you do that way, right, you're going to have much less significantly an overlap of the coronary ostia and the commissures of the new valve. So definitely that's the best thing to do. That increases very much the likelihood that you're going to have good coronary access after you need after the valve implantation. So my very good friend Marco Barbanti published the REACCESS study on Jack, and basically the REACCESS study was a single center. This is my old institution when I was in Italy, but it's a single center study, and overall, right, they had more difficulty on the study getting access to the coronaries through an evolute versus a sapien valve. However, in this study, there was no formal commissural alignment routinely performed, right? So that's important to highlight that. I think us as advanced operators, we do need to always make sure, right, that we do have commissural alignment. As I said, depending on the patient you have in front of you, right? If you cross your arch, you look at the head marker, it's in the outer curvature, you're good. And with the FX, you're going to see when you're deploying the valve, you're going to see the two golden markers on the right-hand side and one on the left-hand side. That's going to show that commissural alignment has been achieved, right? And then a big deal here was that the misaligned supraannular transcatheter valve, of course, low sinus of Valsalva, right? And higher transcatheter heart valve and sinus of Valsalva relation are the highest risk for impaired coronary access. So the lower sinus of Valsalva, right, or the low height of the sinus and the anatomy of the patient, you cannot change. That's unchangeable. However, we as operators, we can perform commissural alignment. We have to think about it. We have to remember to try to do it all the time. Just going here. And I challenge people. People say, "Oh, but it's easier to get coronary access with sapien." That's not accurate information. And I think Toby Rogers published this very interesting paper here showing that you may still have difficulties having coronary access to the sapien, and then that's largely dependent on patient's anatomy, right? This paper actually was very interesting because not only he looked at this, but also the possibility of doing a TAVR in the future, right? So that's largely dependent on patient's anatomy, right? So the ability for you to have access to the coronaries is to start with depends on patient's anatomy, right? And then obviously the factors that we can modify, commissural alignment is one of them, and then you can achieve that with evolutes as well as with accurate, but not with sapien. This is another interesting study that Giulio Stefanini also published on Jack intervention. I want to highlight the fact that this is a multi-center study, right? And PCI was reported, success was reported in most of the cases, and there was no differences between balloon expandable and self-expandable valve PCI in this multi-center study. Whereas remember that the first study from Barbanti was a single center study where commissural alignment was not performed. As we know, the implant PCR post-TAVR is not very frequent, but obviously with low-risk patients, young patients, we always have that. We must take that in mind. This is just published this week. This paper, the Align Access Study, Giuseppe Tarantini published on circulation intervention. And I want to highlight this figure of this paper, that the predictors of impaired coronary access after TAVR, right? One of them is actually the most important one, is a non-aligned supraannular transcatheter valve. So it is of utmost importance for us, for every operator, but I think for us, everyone here, right, that we are, I think I consider ourselves advanced operators, that we do a lot of cases. We do have to be able to perform commissural alignment. We have to think about it, right? And obviously, as I said, the anatomical issue of the sinus of Valsalva height, that one we cannot modify, obviously. What we can do in this situation, for example, is to, on top of performing commissural alignment, implanting our evolute valve a little bit lower to take the skirt out of the coronary ostium, which is going to make your life much easier. So, not only it's important to perform commissural alignment, but I want to go beyond a little bit, which is, it is important that we do understand the technique to reaccess the coronaries, and by sizing down catheters, liberal utilization of guide extensions, which I use a lot when I have to do a PCI through the cage, right? As I said, analyzing the risk and benefit of a deeper implant in case you are concerned with the skirt being in front of the coronary ostium, not for acute occlusion, but rather for the coronary access down the road, right? The choosing the device, again, I feel very comfortable with evolute as long as I can perform commissural alignment. There is some people suggesting doing the CT prior to an elective coronary angiogram, which honestly I do not think that makes too much sense in terms of contrast and radiation utilization. But here, the last line here, that a future iteration of the valve, including larger cells in front of the coronary osseous. This is also something that Medtronic is working on, to have larger cells in front of the coronary osseous. So not only we're going to be able to perform commissural alignment with evolute, but also in front of the coronary osseous, there will be much larger cells, which is going to facilitate very much the possibility for us to have access to the coronary arteries. I think this is my last slide. Thank you so much for your attention.
Thank you so much, sir. Again, wonderful as usual, and a lot of learning points. So we'll move on to the panel. Any comments from Anuj, Swaroop?
No comments really. Everything was well covered, and it was very educational talk, especially that concept and interaction of the sinus of Valsalva height and other points are also elegantly covered.
Dr. Anantaraman?
I think basically I think it's about practicing. As we are discussing, Rajeev and Swaroop and I, that I think for every TAVR that we do for a learning curve, it's better to, I think, engage the coronary as a practice before, so that in a emergency situation we don't start learning there. So we were just discussing whether we should, after every TAVR that we finish, whether we should start engaging the coronaries just as a thing to practice, so that we don't face the situation as a new thing when the situation arises.
Fantastic. That was a great presentation, Dr. Attizzani. Now, I saw the paper, I think it's in your LinkedIn as well, and the TAVR Align. Now, one important point you have made in that paper and in the presentation as well, I think people always talk about the difference between the balloon expandable and self-expandable, and the coronary access being difficult with self-expandable. But I disagree with that. It's not difficult, especially with the alignment we have made, and with the TAVR Align study showing it. The balloon expandable, 95% of the time you can access the coronaries, and during the initial implant, if you have done the commissural alignment, and if you have done your cuspal overlap and got the depth right, I think the access will be same 95% plus. There will not be any difference, full stop. I think that has to be put to bed. So there is not going to be any difference, because people always say there is going to be progression of the coronary in this patient, so I will put a balloon rather than a self. That should not be the decision-making thing anymore after your study, which you have clearly shown. Second thing is, I think as Anju mentioned, it is always good practice when you put a valve, rather than just taking an iotogram to confirm your coronaries, in the initial stages, you take your normal catheters and access that coronary. So that will become a practice. And when you come for emergencies, it will be much easier. So as Dr. Attizzani has mentioned, wire, catheter, very liberal use of guide extension. That has to be your practice, very liberal use of guide extension. And with that, I think your coronary access will become much easier. That was a fantastic presentation. Thank you.
Dr. Rahul Gupta.
Thank you.
I think excellent presentation, excellent comments. Just one quick. So, what are the choices of your catheters for accessing the left and the right? Usually, in most of the cases,
I usually go with a JL 3.5. This magic number of going like a 0.5 smaller. So JL 3.5 and a JR. I just use a regular JR for the right coronary. Then there is also a discussion of going radial versus femoral. I feel like it is easier to go through the cage via femoral approach. But a lot of people go with radial very well. So I just feel like it's a little easier to go via femoral. But I always start with a JL 3.5 and a regular JR. And then I don't like the EBU very much to do PCI in the left coronary through the cage, although I've done before. But I always try to go with a JL, and obviously then go with a guideliner should I need more support or deliverability. If it's more like a circ PCI, that then I usually use the guideliner very liberally for through the cage.
Thank you.
Thank you. Uday, any comments?
No, sir.
Yeah, Dr. Attizzani, there was one question from my side. I think many time the TAVR is done in one center and the coronary access probably needs to be done at another center. One of the things which I think is being emphasized now is after the valve has been deployed, the C-tap, where exactly it is on the inner curvature in the LAO projection and where it is in the RAO projection, that actually helps in understanding whether during the initial implantation the operator achieved a commissural alignment or not. So that will give confidence to the operator who is regaining coronary access. If you can just enlighten us about that particular aspect, it will be helpful for those who are starting to engage coronaries after TAVR.
Oh, absolutely. Let me share my screen again because I can show you that exactly what you're talking about here. Let me see if I can go back on my slides here. Do you see my slides?
Yes, very well.
What you are alluding to is exactly this here. So the C-tab the evolute, the final C-tab, yeah, the presence of the C-tab and that position, as you mentioned, right, would be the position that people would, when they would see this, right, they would say, well, they were able to achieve commissural alignment in this procedure, and therefore my life is going to be a little easier here, right? The problem that I see with this is that, to be very honest with you, is that the majority of this like community hospital interventions that they have no clue of what this means. They're going to look at that and they don't know what it is, right? So I think it's important for us to also educate our colleagues, right? So to educate on how to do coronary access post, what are the tips and tricks, right? And also to look into these images and say, well, this the coronary in this case commissural alignment was achieved, then I'm gonna have an easier life versus a situation that you will have more trouble, right, having access to the coronaries. And it doesn't mean that sometimes there have been cases, right, that I didn't have like precise commissural alignment. Sometimes patients that were done elsewhere as well, that have to do the PCI through the cage. It's much more difficult, obviously, but it's also feasible. Mostly when you go with the guide liner. I've done cases that I have to wire the coronary with your guide catheter a little bit out, right? You wire all the way down, then you go with your guide liner, and once your guide liner is in, then you push your guide catheter through it, over it, I should say. And It's not as easy, obviously. Let's be very real here. It's not as easy if you don't have commissural alignment. But yeah, I think you made a good point. When people see this, they can have that, they can rest assured that definitely their lives are going to be much easier. But most people, when they see this, they have no clue what that means, to be honest.
Yeah, thanks so much. I think Dr. Amit Chaurasia is in security check, so he may not be able to give his presentation. Probably we'll have another session. I think I'll just open it up for final comments before we just summarize the session for the benefit of the audience. Any comments, Swaroop, and final parting comments from Swaroop, Anuj? For some reason, we are not able to hear you, Swaroop.
Am I audible now?
Yes.
Yeah, no comments really, because most the presenters discussed most of the things in their talks. So over to you.
Anuj?
Nothing much, but basically I think it was a good consortium of the troubleshooting that most of the times we all land up in, and I think I should thank everybody to join in, for people from India so late on a weekend, and for Dr. Attizzani so early in the morning. Thank you so much.
Dr. Uday?
It's very enlightening for newcomers like me, sir. So very insightful. So I'm more confident to deal when these situations arise.
Dr. Rahul Gupta?
I think all very well presented, and very good comments from Dr. Attizzani and everybody else. I think a lot of learning for everybody, all of us, and everybody who's viewing this webinar. I think all of us are enlightened.
Thank you so much. Dr. Anantharaman?
No, that's a very nice session, sir. From basics to difficult access, as well as sort of the most important thing now especially the alignments and the outcomes. The one important thing I would like to highlight for people who don't do much TAVI is, if you end up with the acute coronary syndrome case, you start with an iotogram. You put your pigtail and take an iotogram first. That gives you lots and lots of information about whether the occlusion is in the ostium, whether it's beyond that new disease, whatever it is, and also where the implant is, all different things. So I think in acute coronary syndrome, rather than wasting too much time trying 5 different catheters, this and that, you just go straight with an iotogram, and then you select the catheters, and you'll be able to do a successful procedure. Otherwise, fantastic session, and I thank Rajeev Menon as well as AIG and Medtronic for this opportunity. Thank you, sir.
Thank you, sir. Dr. Attizzani?
No, it was really a great session. I'm really happy to be part of it. I appreciate you guys having invited me. So it's great to see my friends from India. I'm very much looking forward to welcoming you here, and also looking forward to going to India soon. It was really a great session. Thank you so much again for inviting me. Great talks, great cases. It's always a pleasure. Looking forward for the next one. Thank you.
Thank you so much. I think before we close, for the benefit of audience, I'll just couple of minutes briefly summarize which at least I learned from this session. I think in the alternative access, we came to know that it is safe. We need not really worry when the situation demands it. Make sure that a surgical backup is there, and always a surgical cut down is safer than percutaneous in some of those cases. And very interestingly, carotid has less chances of stroke than subclavian. In small annulus, we came to know that definitely self-expandable is better than balloon expandable, and far better than a surgical redo valve. And always remember that need not get perturbed by the echo gradients. There is definite discordance between echo gradient and cath gradient before we jump to certain conclusions. Valve in valve, we learned a tremendous point. All valves less than 21 mm need to have some modification. The importance of implant depth, which was emphasized repeatedly, and how to do a valve fracture was very elegantly shown. And very importantly, the fact that chimneys are not helpful and should not be used as a routine strategy. Commissural alignment, it gives us confidence to know that there is not much difference between the type of valve we use, and it can be engaged, and definitely probably femoral is better than radial. And as Dr. Anuj mentioned, if for the people who are starting off, if they can routinely start engaging all the TAVRs which they are doing, it will be helpful in emergency situations. I think with that brief summary, I would again like to thank Dr. Attizzani, Dr. Anantraman, Dr. Rahul Gupta, all of you who have actually taken your time out and spent with us and enlightened us in different aspects of TAVR. And as Uday mentioned, I think all of us will be better operators when we step into the cath lab tomorrow. So thank you once again, and with those comments, we'll close the session for today. Thank you so much.
Thank you. Bye.